Hi, everyone. I just wanted to say welcome. Um, we're so happy to have you guys here with us, and we're excited to get into this talk. The title of this talk is Race, Ethnicity, and Ethics in the Time of COVID-19. And my name is Ruthie Ali. I'm an M2 second year here at Rush Medical College, and I'm also a CINEME Vice President and Ethics Summer Researcher. That's my involvement with the talk today. I want to thank everyone for coming to the talk again, and I'll give our two other organizers a chance to introduce themselves. So, Gina, if you can go ahead.
Sure. Thanks, Ruthie. So my name's Gina Piscatello. I'm one of the palliative care attendings at Rush and do ethics consults as well. So I'm working with Ruthie and Chise this summer, and this is a project that they both came up with together, and I'm very excited for it today. So I'm looking forward to it. Thank you all for coming.
Hi, everyone. My name is Chise Katie, and I'm a rising senior at the University of Illinois, Urbana-Champaign, and I am one of the Rush Summer Research Scholars with Rush this summer, and I'm really excited for this talk, and I hope you all enjoy.
Okay, great. Thank you, guys. So this event is hopefully one of many more to come, and it's hosted again by Rush Ethics researchers and sponsored by Student National Medical Association. So I'm going to give Tosin, we have our president for CINEME here with us, so I'm going to give her a chance to introduce herself in a little bit. So this talk really was birthed from a desire to keep the conversation going with regards to race, racism, and inequality in healthcare, specifically when it comes to valuing and caring for Black and Brown lives. As we have all heard from our university and all around the world, that the statement of Black Lives Matter, but beyond words, we want to see the statement applied to our patient care here at Rush and beyond. And as we all know, with the recent events related to the killing of Black people, primarily Black men at the hands of police and others, has resulted in an outcry against police brutality and racism across the nation and the world. And it has opened a window of opportunity to educate and learn about racism and its impact and create awareness, raised awareness of the necessary work and responsibility we all have to rid our society and our systems of this crisis, especially when we're experiencing a global pandemic that's disproportionately impacting the same population. Today, with case-based discussions, we hope to showcase that anti-racism is not a political issue, it's not just the responsibility of few groups, but it's everyone's responsibility, especially in healthcare, as it is ingrained in our oaths for ethical, humane care of our patients. So we're very fortunate today to have with us amazing organizations at Rush that are working just to do just that. We have CINEME, like I said, Diversity and Inclusion Committee, Racial Justice Committee, so far, Student Optimistics for Anti-Racism, Rush Immigrant Health Group, and various others. If I didn't mention any others, you can feel free to put it in the chat. So now I'm going to give Tosin a chance to introduce herself.
Hi, everyone. Good afternoon. Thank you guys so much for coming. I am the CINEME chapter president here at Rush. So Student National Medical Association is a student-run national organization, and it's dedicated to supporting underrepresented minorities in medicine and addressing the needs of underserved communities. So there's chapters all over the United States, and one of the goals of CINEME is to be a source for credible and accurate information relevant to minority health issues, and also in boosting the field of medical education, so that we're recruiting more physicians of color and better able to serve populations and communities of color. So I'm really excited to see where the discussion goes today, and thank you guys so much for coming.
Thank you, Tosin. I'll now give the mic over to Gina, and we will start our talk.
All right. So this, hopefully, the plan for this today is it's going to be a true discussion. So all of your opinions, all of your perspectives are very important. We love once you get to the cases, just unmute yourself and add to the conversation. If you're more comfortable putting something in the chat box, that's totally fine, and we can help read what you wrote there. If you want to private message us as well, you can private message Cheese, Ruthie, or I, and we can read your response anonymously as well. So to get us started, so our learning objectives, we're discussing how race, ethnicity, and medical ethics are integrated with each other. Discuss how contextual features such as patient race and ethnicity affect patient health, and discuss how structural inequities affect medical care. So just a little bit of basics before we get into the cases. So clinical medical ethics is very patient-centered, like we have an actual clinical case that we need to come up with a plan for what are the ethical options in patient care. And so you might have heard of before, like bioethics has those four, their model is using like autonomy, beneficence, non-maleficence, justice. And those are very important. Bioethics is that large, like philosophical field. It includes biology, theology, very wide breadth. Clinical medical ethics is a little bit different in that it's focusing on an actual patient case that we need to come up with a decision on that. And so clinical medical ethics uses the 4-box method to kind of help go through every case. And that's what we're going to kind of go through today. That includes medical indications for the patient, patient preferences, patient quality of life, and then contextual features. And I think sometimes with contextual features, you know, I've heard people mention before is race and ethnicity. Is that really a part of ethics? Well, the answer is yes, because a lot of these contextual features, along with medical care, absolutely impact a patient's medical care that they receive. So legal issues, financial issues, religious issues, these all impact the patient's actual medical care. And this is what we're seeing a lot of the inequities that we see with patients. It's not just due to their health alone, it's due to all these other features, as I'm sure pretty much everyone on this phone or this WebEx today already knows. So how ethnicity and race intersect with one another. So just kind of a brief overview. You know, with COVID, I think we've really seen these disparities be exacerbated. They've already existed, and I think now there's getting more prevalence in the media about them. You know, Black and average than white patients. And the rate of death for Black and Latino patients is almost 2 times as high as when compared to white patients. There's many factors involved with that. You know, we had these segregation that we can see within our own city of Chicago, how African Americans are predominantly on the south side and the west side, as well as Latino are segregated from white populations, and that absolutely impacts patient health. You know, we can see with housing, white people are much more likely to own their own housing than other ethnicities and races. Education, access to food, healthcare, all of these things have disparities, and all of these things impact why patients who are Black and Latino, why they have worse outcomes than white patients. So looking at kind of the COVID numbers, so in most states, Blacks' lives are exceeding, the death rate is exceeding those of white patients. And I think like this graph is just so kind of shocking in a way to see how much more Black lives are dying in comparison to their share of the population. So we have a true issue here. And so I think our first case, what we're going to discuss is about vaccine distribution. So I think you probably heard a lot on like the news. You know, we were talking about other things like, you know, shortages of care, like ventilator management. You might have heard on the news with that part how there was concern that the way some of the ventilator allocation protocols, some state protocols, hospital protocols, how they were designed, there was grave concern that that would impact minorities of color more than white populations. And I think now, like something that's in the news as well is vaccines. How should these vaccines be distributed for COVID-19? You know, hopefully we have a lot of vaccines when they do become available, but it likely won't be enough for every patient to get at once. How should this distribution happen, especially when certain patients are being affected by COVID more than others? So this first case that we're going to discuss, within the next year, COVID-19 vaccines will likely be ready for distribution in the United States. How the allocation system should occur is being debated by the CDC's Advisory Committee on Immunization Practices. They are considering a 5-tier system with certain groups such as healthcare workers and people at higher risk for developing severe COVID-19 infection being given priority for allocation. They are also discussing giving priority to people based on race and ethnicity, as certain groups have been disproportionately affected by COVID-19. So now I'm going to kind of open it up for all of you. How do you think that these vaccines should be allocated to the general population? So there's many different methods that potentially could be considered. One method would just be true random, that everyone is just given like a random allocation of the vaccines, that if you have like a high enough number, you would be the first one to get the vaccine. So that would be an equitable distribution that way. Others might say first come, first serve, that the people that are willing to get the vaccine, they should be the first ones to get it. And then there are other people who are saying that certain populations are affected more by COVID, they should be put at priority for it. So the question that I'm opening it up for is, should we be giving priority to certain groups, or should we be doing more of like a random approach when vaccines do become available?
Hi, this is Dr. Kim Williamson, cardiology. Are you able to hear me?
Yes.
So we've been doing a lot of work with the Rush data. It's actually very congruent with other places, such as Louisiana, that also has a very large published database. And our analysis, if you do a multivariable analysis, it's really what the CDC and many researchers around the world have actually said. It's not about race, it's about risk. And our African American population, and to some degree our Hispanic population, have many of the things that make people die of COVID: obesity, diabetes, and then in the African American population, our hypertension and high cholesterol are there. To the extent that the risk factors, and obviously cardiology is interested in this because those are the same 4 risk factors that make people die more likely from cardiovascular disease. And so we've been fighting the same battle, and now it just has taken on more acuity. So I would say that the most logical thing that would save the most lives would be to allocate the people who are most vulnerable, the people with those risk factors. Now, as it turns out, in Chicago, that's going to be the African American population, the Hispanic population, and that would actually reduce the amount of serious illness. Everybody can get COVID, but not everyone is going to get hospitalized. Not everyone who's hospitalized is going to get put in an intensive care unit, ventilated, or die. And so if we can pick out those people, and I think we have enough science now to be able to do that, that's who I feel should be prioritized.
I totally agree with that. And also someone from the chat agrees. Miss Callie McKinney said that she thinks that the people who are most vulnerable to the virus should be prioritized as well. It also helps in those populations and like those communities, because if they also get the vaccine, that'll help everyone in those communities not be able to spread it to other people and keep other people safe as well.
Hi, everyone. This is Teresa Torres. I think that definitely having a conversation with the communities that are impacted will be of priority, because there is a lot of mistrust with with medicine. I'm just thinking back to the Tuskegee trials. And so if you tell a certain group that they will be first to have these vaccines, I can't imagine that they will be lining up. There will be a lot of questions as to why other groups aren't also being a part of this vaccine. So the messaging will be very important.
And I think to that point, I think my next slide here, so this part, if for those of you that are on the computer looking at this, so Black Americans are more skeptical of experimental treatments like potentially this COVID-19 vaccine. And so the thought is absolutely, if certain populations are prioritized more, are they going to be comfortable receiving it? Could that potentially, if people are less comfortable receiving it, could that impact, if we allocate a certain number of vaccines to this population and they're not comfortable receiving it, could that make it potentially a longer time for other populations who would receive the vaccine to receive it. What do you all think about that?
This is Princess. If that is the plan and we're not deliberate and intentional with the communication, as someone mentioned earlier, but the outreach and who we are tasking to be the community health workers that are supposed to be educating the community about that and addressing their fears directly. And because it's not that they don't have reason to be fearful of the medical enterprise. So being transparent about it and addressing that we understand why those concerns exist and the history of medicine around those issues, and then being able to engage them and like having stakeholders a part of the planning process, a part of the messaging would be really important.
Mm-hmm. Thank you for that, Princess. Who do you think's obligation is to do that, to help like improve trust and improve knowledge about vaccines to these populations?
I think it's the entire healthcare system, because whoever is touching a patient, whoever is in that patient relationship has a responsibility to make sure that their role in it is just, and that we're being intentional and thoughtful in that process. And I think that it's their responsibility as our responsibility as an institution, as a system, to make sure we're providing the right care for patients, which means a part of that is the way we interact and the information we provide to make sure that they can make the best decisions and come with that process as a partnership. You know, we're not dictating to this particular population, but we're going to learn about how we can best support and engage their optimal health.
I just wanted to raise my question. This is Sharon Jadell. As to if there is available data on risk and mortality of individuals of African descent from other countries and COVID. Do individuals of African descent from other countries fare as poorly as they do in the US?
I actually haven't seen any of that. You know, the obesity issue, which is, for people who have not heard this, it's really critical that to understand that adipocytes actually have adipokines, which add to the cytokine storm, which actually harms people with COVID. But more importantly, the adipocytes are the optimum reproductive area for cells for the COVID virus. So they are really shedding, they have higher viral loads, they're shedding the virus more and getting a lot sicker. And so to our understanding, and the same thing, our hazard ratio for being Black was 0.83. That's a 17% decrease in bad outcomes. If you take into account the risk factors. In Louisiana, it was 0.79, a 21% decrease. So Black actually might be protective. The problem is, you know, being obese, diabetic, hypertensive, and high cholesterol.
I think also what should be noted is also historical and structural racism that has limited people's ability to access healthcare or have health care equity parity. Is also kind of symptomatic of other comorbidities, because if you have a legacy of not having adequate healthcare, not having adequate preventive care, not having access to living in a food desert, not being able to have access to transportation that could get you to other places, are also kind of compounding the other issues that lead to those other biological effects of that structural racism.
This is Cynthia Boyd. Can everyone hear me?
Yes.
One of the things I think is key here is the issue around access. And I would assume that most people on this call, when they have issues with their health, they're either able to call or actually visit a primary care physician to discuss their health concerns. And likely that physician has a past medical history on you and is aware of some of those things that Dr. Williams just discussed, whether it's being overweight or having a family history of diabetes or hypertension, or might even having those conditions yourself. One of the problems, I think, with this is that we do have to remember race is a social construct, and that, the population, the human genome has shown that we are more alike than we are different. And there's more variability actually within certain groups of the same race, if you will. The issue here is that, number one, we don't have enough physicians and providers of color, so that trust issue is not as much of a problem. And we don't have enough physicians of color who are able to access these individuals in their community. So I think a lot of this is going to be the relationship that providers have with their community, and what their community has in terms of risk factors and trust, that will then facilitate and be able to meet the needs of those, as Dr. Williams has described, who are most vulnerable. I think it's important we don't get too stuck on race here, although we know there is structural racism. I would say that the one of the things that compounds this is the lack of a diverse workforce. I know that there are physicians at Rush, Dr. Susie Lopez was one, who said that there has been difficulty even reaching some of our own patients when they're admitted who don't speak English. Their primary language is Spanish, and they have been unable to communicate. So I want to add to the mix that it is critical, as we discuss this, that yes, we want to make sure we reach those who are vulnerable, but this also highlights the lack of representation of physicians of color in medicine.
Absolutely. And there's a recent report that was published by the AAMC about healthcare equity and impact, the shortfall that we have as a nation for people, particularly African Americans, and that, by the time that the whole country is going to be affected by the healthcare shortage of physicians, that African Americans are also going to be acutely felt. That with the just one African American physician, it impacts the healthcare equity about 450 patients. And so just having one additional African American physician. So we know that African Americans, other minority physicians, are 5 times more likely to care for not just patients of color, but also medically underserved patients as well. So the physician shortage and healthcare shortage in general is a huge issue.
So this is, I know I'm just a M1 talking here, but I just want to make a point of really agreeing with everything that's been said, but also going back to making sure that we educate the population on why they're being, targeted for a vaccine, and specifically partnering with the community about that. I think that the language that's being used, not necessarily just because I see the ideas in the chat about going to churches and partnering with community leaders, but I would even be more open, we're healthcare providers and we're also taking the vaccine would be really important, because there is a lot of distrust. We talk about it statistically and a lack of compliance, communities and things like that, but there is a lot of distrust. And even myself as a Black woman, when I go to the physician and I'm trying to be a healthcare professional, I still have an element of are they really going to take my pain seriously? So I think really emphasizing that, the communication aspect, and making sure that we are also taking this vaccine. We're not just giving it just to Black people. And we're also, those are very real fears of being wiped out or being targeted. And that's not based in not reality. Those are historical events, and they are even happening still today. So I think really focusing on that communication, why they're at risk, but also making sure it's noted we're not targeting you in any kind of negative sort of way, is really important. That's all.
Yeah, Sharice, thank you so much for that. And I think that's a big concern as well, is, what if this I mean, it should be safe. If it passes through the clinical trials, it should be safe. But what if it does look like we are targeting a certain population to give it to? And what if it wasn't safe? Like that distrust is a real thing. I'm wondering, so, we've talked about, and I think, Dr. Williams' point about like doing prioritization based on like data, that's great. Does anyone have a different idea, like rather than using like data to prioritize, does anyone have any other ideas for how we should allocate? Or is that kind of like, does everyone kind of agree that using data is probably the best way to allocate who gets the vaccine first?
This is Erin Emery Tiburcio. Can you hear me?
Yes.
Thank you. So if we're talking about the data, and both to Dr. Williams and Dr. Boyd's points, if the risk factor is less about skin color and more about comorbidities, is there a reason why we couldn't target based on comorbidities to begin with and overrepresent access in communities of color where access might be limited? So rather than focus on the race, focus on the health, but assure that folks who are most likely to have those issues have the greatest access?
Yeah, I mean, that makes total sense. Like, could we as a society come up with a prioritization that would equitably allocate it? Even the differences between states, like should this be a national wide allocation where there's one set prioritization that's used for all patients to determine the allocation of the vaccines? Does it need to be state specific? Do we trust data as a society that we would actually even consider implementing it like this? I think that's why, the CDC is coming up with these guidelines, and they ask for community input on it as well. But do we trust that the US population as a whole is going to even trust data to support the allocation of vaccines based on the data?
Hi, this is Teresa again. I completely agree with Dr. Emery Tiburcio in approaching this as we're targeting people based on comorbidities to reduce the distrust in the communities. And I think you can hit two birds with one stone as healthcare providers, speaking with patients and saying, these are the things that we need to do to decrease your risk of death from COVID-19, and we also have this vaccine.
All right. And then, part of the discussion as well was, it was always that, healthcare providers would be given priority for these vaccines, and first responders like firefighters, police officers. Should those groups still get priority because they are caring for patients, or should it be truly based on risk level? Meaning that potentially, populations in the community would get the vaccines over healthcare providers that are putting their lives at risk caring for patients with COVID.
This is Cynthia Boyd, and I think that makes sense if you think about how we operate in our institutions relative to making sure that people have had TB testing, for example, that they get hepatitis screening and vaccinated, and to prevent those illnesses for people who are in direct contact. I think one of the things as well as we discuss this is, as these vaccines are being developed, the clinical trials I'm hoping will involve individuals that represent those that are likely more prone to this. We know that in the past, a lot of studies, particularly with heart disease and hypertension, has been done on a very homogeneous group of individuals and didn't include women, didn't include people of color. The other point here, I think, is for those who have contacted COVID who didn't have comorbidities, but were in very close quarters, families living in multiple members of a family living in close proximity out in the community, and come back and share that because they didn't have the advantage or to be able to quarantine or whatever. So we know that in our urban areas, our redlined areas, that there is a concentration of certain people, certain populations who don't have the mobility to go to their basement or to go to their garage or whatever in quarantine. So I think that's another element that we have to think about. Those with those jobs that are in the public, whether they're a cashier or a bus driver or whatever, who don't have the privilege to be able to self-quarantine, to take off and do things from remotely. So I think as this plays out, that's another element. And again, I'm going to say that it is critical that our organizations have a relationship with their communities. And by that, I mean that there is engagement. I think Rush has that engagement where people are able to access the community instead of the community accessing us. For the providers to access the community, much as was done with Franciscan homeless shelter, where we had individuals from Rush going there. And so part of this is a key piece of this is access, but recognizing beyond the comorbidities, some of it is just the fact that the way people live. And I think you all started off by talking about housing being a problem in terms of the racialized aspect of this problem.
This is David Ansel. Cynthia, thanks for those comments. We actually do have a vaccine trial that's being launched. Beverly Shaw, Dr. Shaw, and infectious disease. And at the same time, we're trying to organize mobile testing out in the communities. When COVID first hit, the testing was largely unavailable, or if it was available only at large medical centers. Only later in the epidemic did it move into communities. But many of these things are fixed spots in communities and not easy for people to access. Jolene Lozano, who many of you might know, the medical students at least, who works with very closely with Sharon Gates, has been organizing testing, the mass testings and getting 1,000 people at a time. We're actually putting a proposal in to do mobile testing to take to churches and such, with the idea of also taking the vaccine out, a vaccine trial out. But the issues of mistrust are huge, and to do so. But I do think there's going to be opportunity if students or others are interested in this work. Please reach out to me, and I'll connect you with Dr. Shaw, because I think there's a lot of community education that has to be done for these kind of trials to be successful. And even the testing, the churches are concerned about testing in churches and in the issues of exposures. We have to think about the physical sites. How do we actually create a space for going out in the community, particularly in the fall when you're going to have flu and COVID, to make the testing sites not just safe, but feel safe to the participants.
All right. So I think that was a great way to kind of end this discussion about how Rush is going to, the action plan for Rush, how they're going to help with distribution of vaccines. So does anyone have any final points before we move on to our second case of the day? All right, we will move on. So case 2, this is a case that we saw repeated over and over again at Rush during when our numbers of COVID were very high in the hospital. So a 70-year-old male patient with history of diabetes, hypertension, COPD, was admitted to the medical intensive care unit with pneumonia due to COVID. On admission, his respiratory status declined, so he required intubation and placement on a ventilator. And he remained on the ventilator 21 days without any sign of improvement. He's not been awake or alert during this admission. The medical team informs the granddaughter a decision must be made about considering tracheostomy placement versus considering removal of life-sustaining treatment. The patient's granddaughter has been receiving calls daily from the medical intensive care team. She's aware the patient's condition has not improved, but states she is not ready to make a decision to remove life-sustaining treatment, as she and her father are hoping for a miracle. The granddaughter states her grandfather told her he would never want to live on machines. He feels very bad he's currently requiring life support. When the medical team hears this, they explain to the granddaughter that decisions should be made for the patient and with the patient's wishes. And if the patient did not want life support, a decision should be made not to continue it. When the granddaughter hears this, she tells the ICU team that they are giving up on her grandfather and family, and that they would not treat a patient of white race in the same manner. So we're going to kind of go through this case step by step. Does anyone have any questions about the medical indications of this case? Anything about the patient's medical history? Getting on to patient preference, what is the patient's preference in this situation? All right. So in this case, the case tells us that the granddaughter saying that the patient would never want to live on life support. So we can kind of, take from that his wishes would be to not be living in his current state on life support. Regarding quality of life, we'd have nothing in the case to help tell us about what the patient would value with his quality of life, whether he would be okay on machines or not. We just had the statement that in the past, she believes he wouldn't have wanted to be on machines based on past knowledge of the patient. And then contextual features, do we have any idea about if, concerns about ability to pay is playing into this case, anything like that? It's not stated in the case, but absolutely those are concerns that come up. And I think one of the big contextual features of this case is the concern that race is a factor, that the medical team is recommending consideration of withdrawal of life-sustaining treatment based on the patient's race. So this is open up for everyone as well. Who should be the right person to make decisions for this patient? And this, I mean, just by law, who would make decisions for this patient? Because I know this has been another thing that, especially during COVID, so many of these patients weren't able to make decisions for themselves. So we have to go to the legal surrogate or the legal power of attorney. Who for this case would that person be?
So in the chat here, we have granddaughter, a wife or a child, next of kin, spouse with surrogate if there's one, adult children next, son.
Thanks for that, Ruthie. So I think, this is something, since this is an ethics conference, the point of this is there is a lot of variety in responses, but there is a true legal decision maker in this case. It's something that we have to be very protective of. If a patient can't make decisions, we really should be going to that legal decision maker. And so we should know how to determine that. So in this case, the correct answer would be, first of all, we should ask if the patient has a power of attorney. That would be those who mentioned that point. Yes, that is true. If they didn't have a power of attorney, the legal spouse would be the correct decision maker. If they didn't have a legal spouse, then it would go to all adult children equally, and all should be contacted to help make decisions. So frankly, the granddaughter, there's probably someone in line before the granddaughter to be making these decisions. And I think sometimes, especially when patients, we're dealing with a lot of patients, like the hospital was very overwhelmed with COVID patients, you kind of go with the person who's at bedside, but that person at bedside might not be the legal decision maker for the patient. Now, legal decision maker, that's one thing. Who would be the moral decision maker for this patient? The difference is a moral decision maker is a person who knows the patient the best, who can help best speak for the patient's wishes. Who would that be, do you think? So that would be more of, in this case, the granddaughter's at bedside is present. The granddaughter's telling you what the patient's wishes are. So the granddaughter's the moral surrogate. If we were in a different state like Minnesota, we would go with the granddaughter to make decisions if she knew the patient's wishes the best. We just have different laws in Illinois. And so in Illinois, sometimes you end up going with the decision maker that doesn't know the patient as well, just because the law kind of forces us to go with that. So before we go ahead kind of anywhere with this case, it's good to know who the decision maker is, because that's the person that is going to be helping with the decision. And then moving on here, what is the right course of care for this patient? How should the medical team respond in this situation? So they're being told by the granddaughter, you were saying to withdraw life support, and you wouldn't say the same thing to a white family. How should they respond to that?
I have a question.
Yeah, of course.
What is the typical amount of time that you would stay on a ventilator? I think is my main, like, what is the, like, clinically, like the average, or what's like recommended time? Is there like a minimum or a max?
That's a great question.
Yeah, because I would base as a person who has to constantly advocate for their own family, I can kind of see where she's coming from. I can see like wanting to do the patient's best interest, but also I've like read a bunch of stories where like man on ventilator for like 60 days, man comes back after, so like if you're constantly like seeing that and then you're asked after, what is this, 21 days on a ventilator, I can kind of see that perspective. So my thing would be like, what on average, I guess in this hospital, like the average of time of someone being on a ventilator, and then like breaking that down probably in statistics of race and gender would probably be very helpful just to know, because that would give more footing for like the healthcare workers themselves to be like, this is not I'm not doing this based on race or bias. Because I don't know, I personally can see that from both elements of that, especially having to advocate for your own family, and feeling like you might be getting shortchanged. So, yeah.
So typically during COVID, that's such a good point. Thanks for bringing that up, Sharice. 21 days is kind of the time point, which is a longer time point than normal. Normally like about 2 weeks for any patient, because of the risk for intubation of like tracheomalacia, risk of increased ventilator-acquired pneumonia being on the ventilator. For any patient, like 14 days usually would be the time where you need to decide whether they get a tracheostomy placed to help decrease the risk of the having an endotracheal tube in. Or withdrawing life support if that was within the patient's wishes. So normally it was 14 days, but with COVID, because people took longer time to recover, 21 days was more of that time point. So that's such a good important point with this case. So the 21 days, this would be really for every patient. And that was very equal kind of across the board. 21 days, we need to make a decision about tracheostomy to help protect the patient. They would still be on the ventilator, but it would just be overall safe for the patient to have a tracheostomy placed versus having the endotracheal tube in. But some patients never want a tracheostomy in. They don't want to be on machines. So that's why it's kind of a decision in tracheostomy versus withdrawal of the endotracheal tube. Something has to be done. The endotracheal tube just can't stay in.
Gina, this is Rich Abrams talking. In some ways, it seems like the ventilator is almost sort of the confusing part of this issue. The issue really has to do with the not improving piece or not awake and alert piece. I mean, we've certainly seen patients who had COVID or other problems that have been on ventilators actually quite a bit longer, and yet they showed signs of improvement during that whole time. And so, and I understand sort of the inflection point around the days. The tracheostomy is actually for the patient's safety and for the patient's health. So it's I don't know if it shouldn't be viewed as a negative, but it seems that the more important issue is the lack of, not the lack of improvement, it's essentially that the lack of responsiveness that the person has at this time.
Yes, that is a very good point. And I think, some of the comments, and maybe Ruthie and Chize, you might have caught this more, like about how should we respond to the family? Like, what should the team do in this situation? Did you happen to catch that from the comments?
Yeah. Here, Laura said, if there's a staff person who has a good relationship with the granddaughter, to be able to talk to her about his wishes and the goal of honoring his wishes. And Teresa said, holding a conversation with the team and the granddaughter will be important. Allowing the granddaughter to be heard and provide insight is needed.
Yeah. And then let's say with this case, let's say the course is escalated, like the family starts getting very upset. The family's at bedside and there's some concern that they might get violent. They've never shown any violence before, but they're raising their voices. What do you think is the appropriate care of plan of action from the medical team at that time? So they're just raising their voices. I think what I'm trying to get to here is, sometimes security is called on these families. So, they have a family member that's dying in the ICU, and sometimes security is called. Do you think like calling security, is that going to be helpful to this situation? Like, when should security be called? I think part of the point I'm bringing up is like, actually just today in a patient's room, I saw a sign in their actual room in the hospital. And it says like, if there's any concern for violence, like, we will call security and then call law enforcement. And I thought that was kind of interesting to have in a patient's room. We absolutely have to keep staff safe, but I just wonder, like, perspectives of those on this call right now.
Hey,
Go ahead.
this is Dr. Carl Lambert. I was actually just talking to a family member. He had a brother who was in the hospital, had end-stage cancer, and there was all sorts of commotion about goals of care. And unfortunately, in that case, security was called preemptively, and the family was so devastated. They lost time with that family member who subsequently passed. And just discussing that with him, I just tried to just explain to him that your raised voice should not have been equated to violence, and that it's already an emotionally high time, that every effort should be used to de-escalate the situation. Instead of security, maybe bringing in a chaplain or someone else who can provide emotional support and just reaffirm the patient and their family during a challenging time.
I saw a lot of good things being said in the chat. Like, find a way to de-escalate and remove or move the family to a family room for more discussion instead of in front of the patient. Understandable that emotions are running high and empathy is needed, especially when end of life decisions need to be made, which is so true. Also, no need to call security for these voices. There shouldn't be security called unless there's a clear immediate threat.
And I also think if the goal is to build trust with the patient, and we should all, I think, as physicians, have an understanding of the context, like as future physicians for me, but of the context of this nation, and that police brutality, right now it's being filmed more, but it's been happening for years and years. And so I think we have to kind of understand these contexts when we're dealing with when we're dealing with the situations, and kind of take a step back and consult the family and do what is needed to de-escalate, like everybody said.
And I think from the standpoint, especially, during the times when our COVID numbers were higher, all the staff members were stretched so thin. They have multiple patients that they're caring for who are intubated, needing, a lot of support from them. I think potentially like triggers were pulled quicker, on calling security or consideration of calling security because they didn't have as much time to think. We all have these inherent biases as well. I think certain people raising their voices might cause some concern more than others for us. And like, how do we deal with our own internal biases as well when caring for the patients and their families?
Hi, everyone. This is Teresa. I saw Callie commenting, and I've had some nursing colleagues on the floor that have been so appreciative of Callie coming in when they couldn't respond appropriately to the situation. So I will also just say, know your resources. This is so great in theory to say, oh, I would be so calm and walk away and guide the family, but we respond differently in the situation. So I really liked Arlene's mentioning of escorting to the family room. I think that could be a great way to kind of take a pause, maybe step away, but also know your resources that can help de-escalate. Sometimes that's not possible, even if going to a different room. If there was distrust, that is not going to help. So having someone else come in and help guide the conversation will be important.
This is Cynthia Boyd again. I totally agree with that, this is an opportunity where cultural competency comes into play, but also recognizing perhaps your own biases and perhaps you are missing something. So I think the first de-escalation is not to have the conversation necessarily right in the room, but to have individuals help have the conversation who might understand the dynamic between the granddaughter and grandfather a bit more and be able to discuss more in detail, as someone mentioned before, the not having any signs of improvement and discussing surrogates or whomever might else be contacted. But I absolutely also agree. I think there was a question in the chat for the individuals involved. Would they have contacted security or the Chicago police if this were a white family who raised their voices? That's where the check comes in on a person's bias.
And I think, to those points, how do we check our biases? Like, is that an institution's, obligation to help staff, to help train staff so that we don't have these biases? Or, I think we'll all have biases, but how do we put them into check to reevaluate them and see where they're cropping up? Whose obligation is it to help reevaluate our biases? Is it our own internal that we need to be seeking this education on our own? Is it an institutional's, obligation? Is it like the schools that we went to, their obligation?
Thanks for that, Gina. This is Cynthia Boyd again. I absolutely believe it's the organization's responsibility. I think it starts with providing that training, providing scenarios, providing management, but particularly in the healthcare setting. So it's not just administrators. It's important, but I think people right on the health in the healthcare environment, taking care of patients just like this, making life and death decisions. Maybe not necessarily COVID, but someone with chest pain, someone who might have to decide whether or not to amputate someone's limb. All of those things that start to address disparities as well. I think it is the organization's responsibility to provide bias training on a repeated basis, because just doing it once doesn't mean, okay, you're all set, your biases. So at Rush, I know that this is something that is being discussed of how to do this across the organization, but certainly in the health provider arena. And there's enough data in the literature that shows that, as much as we talk about external things like the social determinants of health and structural racism contributing to health disparity, we also need to talk about, and not that this is necessarily a disparity case here, talking about this COVID case, but in general, we also need to talk about internally and how our clinicians and providers have biases that can also contribute to decision-making that can have an effect on someone's health outcomes.
Any other final comments on this case? All right, Ruthie, do you want to help wrap us up?
Sure. I first of all just want to thank everybody for coming. This was a great discussion, and we hope to have more of these and kind of continue the conversation and not let it, die down. These are important topics to discuss. And, I really appreciate everyone being here from different committees and every department. I think it is the responsibility of, all of us in every field of healthcare, working together to show that Black and Brown lives do matter, and having ethical and caring practices. So I will also see if Tosin wants to say some final words.
Don't have much to say, but yes, I really enjoyed this, and I hope everyone else did too. I think it's important to continue having these conversations and not just let them fall by the wayside. Allows us to challenge each other and bring ideas to the forefront and continue pushing the needle forward. So great job, everyone.